Okay, very good. Well, welcome to tonight's webinar. We're going to be talking about chronic infections. Believe it or not, it's kind of crazy, but a lot of your patients have chronic infections, and they don't come in telling you, "I think I have an infection." Basically, they just, they don't feel good. They have aches and pains. Their brain doesn't work well. Something's out of order that they don't realize it. And in the type of work that we do, it's really important to go through a process where we can find the things that are driving problems. Let me give you an example. Actually, I was on a radio show this morning, and I was talking about the fact that when people have problems, the faulty or the problem that people have, or the error that's made, is in thinking that if I find that one thing, then I can get better. If it's high blood pressure, I find that one thing to do, like that one nutrition to take, or that leaf that comes from a tree from the Amazon or whatever. If I find that latest, neatest thing, that'll solve my problem. No matter what it is, what the condition is, maybe it's aches and pains, weight, or whatever the condition may be. But in general, and this is where the error is made, is that these things are generally multimodal, which means there's more than one thing driving them. So infections may play a very big part of somebody's problem, or they might play a minor part. But if they're there, that's going to be one of those pieces of the puzzle that's really driving the problem. So it really is important to get really good at this aspect of your clinical practice. So let's jump right into it, because we have a lot. We have a lot to go through here, and I'm going to make available these slides for anybody who likes them. So that'll be fine for us. So let's start here. First off, with any good clinical workup, there's a process we go through. Patient comes in, they enter, they present into our clinic, and there's some things we can see. We look at observations. How are they walking? How do they look? How do they hold themselves? How do they dress? What's their attitude? So there's different things that we're looking at to kind of help give us a clue to what could be going on with them. So, and the other part of that is we're going to have them fill out questionnaires. I'm a big believer in questionnaires. I like for patients to fill out questionnaires because it gives me a head start. I know some doctors say, well, I like to go on a blank piece of paper and just talk for an hour. One, I don't have time to do that. And two, believe it or not, it's less efficient to do it that way than have them answer questions. Two reasons. If you have them answer questions, they're going to answer questions because you have a standardized thing you're having to go through. They're going to answer questions that you probably wouldn't even ask if you had that blank piece of paper. And the other thing is there's just no way that you're going to, no way you're going to be able to have the patient tell you all the information. One, because you're not asked questions, but also they found through studies that if somebody writes down something, they're more forthright with you than if they're talking with their mouth to you. And it makes sense because we have social cues where people would feel embarrassed to say this or that, but they're not embarrassed to write it down. So I'm a big believer in questionnaires that can give us a leg up before we even see the patient. Then, of course, we go through a physical exam, and through the physical exam, we determine what labs that we're going to run. I don't believe in running $3,000, $4,000, $5,000, dollars, $10,000 worth of labs or whatever you're doing before you really know anything. So there's some clinics that no matter what you do, you come in with this condition, we're going to run a whole bunch of labs on you. And I think that's an inefficient way to do it. And I actually like to just walk through the process so people can, so I can understand it and try to do it as efficiently as possible. Okay, so the next thing is, and by the way, when you do that, that can leave money left over, whatever the case is, that you can do more things if you need to later, or whatever the case may be. That's kind of a philosophy I have. Some people do it differently, and I wouldn't complain about it. But anyway, so then we arrive at a report of findings. We're going to sit down, we'll go through it, and ultimately the lifetime care. So let's move on. In chronic infections, first thing, key factors from chronic infection protocols. All right, so know the possible clinical manifestations or presentations, I should say. Brain fog, fatigue, depression. I got fatigue again. Non-mechanical pain, that's a big one. Non-mechanical pain. They have pain, but you can't. You can't bend the knee around and make it hurt. You can't push around in the back and hurt, right? This is non-mechanical back pain, which means that it's coming from a metabolic problems, and certainly one of those metabolic problems can be infection. Skin issues, if they have eczema, rashes, boils, or even psoriasis, chronic pruritus, that's itching, a mystery illness. And then go on down to this one, where we have possible locations for infections: oral sinuses, oral in the sinuses, ears, GI, bladder, prostate, vaginal tract, joints, skin, brain. Of course, you can have infections anywhere. You can have them in the gallbladder. You can have them in, different areas of the body I don't have listed here. These are just my clinical experience that I've seen the most frequent kind of places. And we're going to talk about blood in a minute while we go through here. All right, so historical findings. This is really important. When you go through and identify infections or anything, you always want to think in patterns. What do I mean by patterns? Well, first we start off with a history. We look at the history, and from the history, and that includes that first part, observation when they first come in, and what they fill out on their forms, and the questions you ask them based upon what they filled out. So you're going to go and look at these parameters and see if some kind of pattern starts to emerge. Certainly, if somebody comes in and they have fatigue, joint pain, and like a mystery illness, like what is this? A mystery illness that's what it is. It's mystery illness. It's an illness that is not really well defined. There's not a fork you can stick on it and say that's that condition. It's just something that's happened where maybe the left side of the body is in pain, but the right side is not. Maybe there's just some weird pain pattern or whatever the case may be. Any of these things would suggest a potential pattern of infection. So let's walk through each one of these because this is important. Chronic elevated temperature. If you have somebody, and I just had a patient recently come in that once a month she has a fever that's pretty high, and then it goes away. She has a fever that is pretty high, and then it goes away once a month, right? So you certainly want to think about something like cancer, but that fits more of a pattern of an infection. So we've gone through the process. We've nailed it down to we know it's a bacterial infection, and she's a fairly new patient, so we haven't found out that's exactly where it is. But we've been doing a lot of work for bacterials. Nice thing about bacterials, they respond to a lot of things, even if you don't know where it's coming from. Now, sometimes you have to figure out where it's coming from to get rid of it. But anyway, so she's actually responding. She's getting better, but I still want to find out where it's coming from. All right, so chronic cough. If they have a chronic cough, they could actually have walking pneumonia. Chronic lymph node swelling. If you have you do an exam on them, you do a physical exam in 6 weeks, 12 weeks, 24 weeks, whenever you do it. And every time that you are, checking lymph nodes, they're always swollen. So this would be an invitation for you to start looking for a pattern of infection. Okay, so skin issues, chronic itching, mystery illness, autoimmune disorder. Any autoimmune case, you have to go through the process to see if they have an infection, because many of them do. And in many of them, not all of them, but many patients with autoimmune, it actually began with an infection, right? That's one of the reasons why, that's another reason why COVID is so hard on people, and taking the vaccine can be hard on people, because either one of those can kick in the autoimmune process. Brain fog, depression. Brain fog and depression are kind of a general vague term, so it's hard to, if somebody has vague brain fog, my first thought is not infection, it'd probably be blood sugar issues, but it wouldn't necessarily be in depression, the same thing. But you still look at it and say there could be infection. Now, this is one I really want you to get, because this is going to make your life easier. Just hearing this sentence right here, or this thought right here, is going to cause you a lot less grief in your practice. I will assure you this. If you have a rapid downturn of any kind, so in other words, you're seeing the patient, everything's going well, and boom, all of a sudden everything got worse, or they went back to where they were when they started, and they come in and they say, I don't know what happened, doc, this isn't working. You've been seeing them for 3 years and they've been doing great, and then they have a downturn. Well, the two things you want to check if somebody has a downturn is you want to check, have they changed, added, or subtracted a medication? You always have to find that out. As soon as somebody comes in and says, oh man, I'm doing terrible now, have you added any medications or changed any medications? Oh yeah, my doctor, prescribed a something, 1 month ago. And okay, how long you been experiencing this? 29 days, right? So you're going to say, okay, it might be the medication. But the other thing is an infection. And I want you to always look at that. When somebody comes on down to a turn in my office, I have an automatic CVC. I'm going to run a CRP. I'm going to run a TSH. I'm going to look at the ferritin iron, because each one of those are really good. They help me find infections, right? That's part of the pattern. I'll go over that in just a minute, but just keep that all in mind. Okay, suspect a virus in the following. If you have a history of autoimmune disorders. Now, viruses have a tendency to drive the autoimmunes more than any other microbe. So also chronic fatigue. Somebody's chronically fatigued. And I'm going to draw just a little bit here on this. So here is the mouth and the brain. Here's the brain stem. All right, sitting right up here is the hypothalamus. So the hypothalamus sits there, and then right here we have the pituitary. Okay, so what happens is this: you get a virus, and on the hypothalamus, you have a section of it that's called the periventricular nucleus. It's the PVN, and it's in the hypothalamus. Now that PVN, one of the things it does, one of the major things it does, is it takes samples from the blood so you can know what's going on, or so it can know what's going on. Because here's the thing: the hypothalamus regulates your blood pressure, regulates your appetite, regulates your metabolism, regulates your skin temperature, regulates a whole bunch of things, right? So it's always taking those samples. But when you have a virus, and the bacteria will do this to some degree as well, but when you have a virus, it likes to land on that PVN, and what happens is now the hypothalamus releases thyroid releasing hormone down to the pituitary, then the pituitary releases TSH, and that's what kicks the thyroid in the pants and tells it, start making some thyroid so we can get this metabolism going. Well, as it turns out, when a virus lands on that PVN, it lands on the hypothalamus, it slows all of these gears down. If you remember from past teachings, if you've seen my stuff, that TSH is really going to be perfect at 1.8 to 3.8. Oh, one of the patterns, part of the patterns we see with these chronic viral infections or even acute viral infections is a TSH that goes below 1. Now, I'm not talking somebody that's fidgety, jittery, they're cleaning their house at 2 o'clock in the morning. When you talk to them, you can't hardly talk to them because they're just that is hyperthyroid. But you're only going to see hyperthyroid when it's less than 0.1, 0.01, 0.001. That's where hyperthyroid. If they don't have symptoms of hyperthyroid, but they're lower than 1, one of the things you have to consider, and probably the strongest thing I found clinically to consider, is some kind of infection. All right, so chronic fever of unknown origin. That's kind of what I was talking about with this lady. But you can also have somebody that just has a slight 99, not even considered a fever, but 99, 100. Well, you need to go in and look at some labs and see if you see patterns of infection. And that's really what I'm going to go over a lot here. So swollen lymph nodes, symptoms vary, mystery illness. Okay, possible symptoms of bacterial infections. If it's acute, then you can see fever, chills, pain, achy body, rapid onset malaise, like, oh, I'm just tired. Rapid downturn. Boy, these bacteria can be really suspicious when you're thinking about downturns. In return of old symptoms, that's what I was talking about. Doc, I don't know what happened. It's not working. We've been, for 5 months, it's great, but now it's just like I started. I think we lost everything. And sometimes people even quit you because they don't know any better. And, bad for them, right? So, all right, so subacute, you can see things like brain fog, fatigue, brain fog, joint pain, non-mechanical pain patterns, and cognitive decline. Most common places for chronic infections, as we talked about before: oral cavity. You want to really look in there, look at the mouth, look at the teeth, look at those things. EENT, bladder, GI, vaginal, prostate, joints, skin, nails, the fungals, and even psoriasis, systemic, and brain. So these are common places. And then, as I said, I'm going to give you these slides if you like them. All right, so potential patterns associated with infection. Okay, so let's start here. So first off, let's talk about the white blood cells. All right, so the white blood cell count from a functional standpoint is really going to be 5.0 to 8.0. Now, let me caution you this. I begin to start getting suspicious anytime I see a white blood cell over 7.0, because there's so many things that can actually influence the white blood cell count. Somebody might have chronically low white blood cell count, and then they come in and see you, and their white blood count is 6.5 or 7, and that means they've got an infection. But if you just saw them for the first time, you wouldn't know that. Or if you didn't have any prior records, you wouldn't know that, right? So what I would say is this: the white blood cells are that count is very sensitive to what's going on in the body, but it's not specific. So in other words, you can't look at a WBC and say, oh, it's that. But it is an invitation to investigate. So somebody comes in, their white blood cell count is 4.5, or it's 7.5 or 8.5. That's going to make me really scrutinize all the other values to see if there's a pattern infection. And then I go back to my history and I say, okay, yeah, the patient is fatigued and they do have kind of some weird symptoms, or they're fatigued and they have a lot of joint pain, or they're fatigued and they have chronic sinus problems, or lung problems, or whatever the case may be, right? So that would fit a pattern, and then I look in the blood to see if I can see the whole pattern going on. So my caution is, when you look at white blood cells, it's sensitive, but it's not specific. It just gives you an invitation. And by the way, I hate to tell you this part, but it's just the fact. When it's somewhere between here, it does not move me one way or the other as far as infection. So I would never look at a white blood cell count and say, oh, it's 6.0, that's perfect. I would never look at that and say, there's no infection going on, because the white blood cell count is normal. You would be amazed at how many times, if you're not doing this work yet, and if you are, you probably know this, but you'd be amazed at how many times somebody has a white blood cell count of 6.0, but they've got a big fat infection. So you can't just go, you just can't go on that. Now, the next thing is generalities. Here's generalities. If your neutrophils are high and your lymphocytes are low, that generally, when we're talking about infections, generally relates to bacterial infection. Generally, I'll say that because you can actually have bacterial infections. I find more common in the gut, but it could be anywhere. You can have a bacterial infection, and actually this thing will flip upside down on you. So you don't just look at that and say, oh, lymphocytes are low, neutrophils are high. Or you don't just say, let me say it the other way. You don't just say the lymphocytes are high and the neutrophils are low. So it has to be, or it can't be a bacteria, because it can. Some bacteria can do it. So on the other hand, if you have neutrophils that are low and you have lymphocytes that are high, we generally think more about viruses. But don't get slipped up on that. Like I said, there are some exceptions, and you can have a bacteria as well. Now, on the other hand, also, I'm going to add this one in here, but Lyme disease and a lot of the tick-bornes like to do this pattern with the lymphocytes high and neutrophils low. Now, if you have Lyme disease, it's very easy, because of the way it suppresses your immune system. It's very easy for you to have another infection, so you can always have 2 or 3 infections going on. Maybe you've got a bacterial infection going on, and it's kind of more pressing issue for the immune system. So in that case, your neutrophils actually could be high or normal, at 60, and your lymphocytes could be at 30, like showing no infection, or the lymphocyte or the neutrophils could be high, even though it's Lyme disease. The reason why it's high is because the bacteria is getting more attention from your white blood cells than the Lyme disease. So if you see a high neutrophil, low lymphocyte, don't just cross out Lyme disease. It always could be there, right? So that's just something to be aware of. Somebody comes in, they said, I had a tick bite, 6 months ago, and I saw this big rash around it, and I've just been tired ever since. That would fit a pattern from history of Lyme disease or some tick-borne. Problem with Lyme disease, it likes to hide in the body, so it's hard to detect. So that's really my issue with that. It's a hard thing to detect by just looking at labs. It's almost a clinical diagnosis, if you will, meaning that you see indirect things like a history that fits, blood work that fits, and so on and so forth. All right, so let's go to the next level. So neutrophils, if they're perfect, you're not having a problem. I shouldn't say it that way. That's not the right way to say it. So if your neutrophils are at 60, it can be an indication that you're not fighting an infection, right? Lymphocytes that are at 30 can be an indication that you're not fighting an infection, right? So, and I say might be because you could have a bacteria and virus at the same time. Viruses generally lower the white blood cell count. Bacteria normally raise the bacteria, white blood cell count. And so you get kind of an average in the middle, and you're sitting at 6.0. You're not at 4.0, and you're not at 8 or 9 or 10. You're somewhere in between because there's two competing things going on. Well, the same thing can happen, with your percentages there. So, you could have both a bacteria and virus going on, and then you have 60-30. All right, so the next thing is, this is really a great indicator, and that's monocytes. Anytime, then they should be below 7, but anytime they're above 7, you want to, it could be either an acute or chronic, but you want to get old records from patients, especially when they're new patients. Get their blood work for the last 2 to 3 years. I'll even take it back to 5 years if they have it. So if they have blood work done and they come in and they have a monocyte, when you do it, that's above 7, let's say it's 8.0, and then you look at blood work from a year ago and it's 8.0, that's at least a stronger indication that they have a chronic infection. If your monocytes stay high, stay above 7, and they just hang there, there's usually an infection going on, and or there's mold exposure they're reacting to. They have a fungus, which is an infection. Something's going on, so that makes you look for some of these patterns. Okay, so TSH, this is really a big one. I love this one. If your TSH is below 1, you really want to think about infection. That is really, that's a good indicator. In fact, I believe so much in that because I've seen it clinically. I haven't seen it written up anywhere. I apologize for that. This has been my clinical experience on this. And I had some information from folks. I don't just say I was a discoverer. But anyway, so the TSH, when it's below 1, you really want to consider that. Now, if it's above 3, it's really not my first thought, but you can have an infection that will raise the TSH because of the stress it's putting on the system. But that's not as usual. Now, the next thing is elevated platelets. There are what are called toll-like receptors on the platelets. And so toll-like receptors go after microbes. So one of the things you'll see when your platelets go above 250, you want to start thinking about the possibility of an infection. If you have something with somebody with a pretty rampant infection, just off the rails, a lot of times, or sometimes, you can see the platelets up to 600, 700. I've seen them 800. But a lot of times if you have infections, you'll see it at like more chronic. You'll see it more like 280, 350, kind of those ranges. If something's more acute infection, you're going to see them maybe 350, 450 that way. Now, if it's a rampant, very aggressive infection, of course, it can be higher. And CRP, anytime your CRP is above 1, you want to think of bacterial infection. Now, the range on it is 0 to 8, the clinical range. This is the functional range. So if you're sitting somewhere, and this is an important one, if you're sitting somewhere between 1 and 8, you want to think more of a chronic type infection. But some people have a bacterial infection, it'll raise up to 10 or 20, or I saw one the other day, 123 from an infection. This guy had a big bump on his back. He was an Amish, and you'd push on it, it was sore. I did a CBC, saw what was going on, and we said, I think you need to go to the hospital. This is a little bit more than we can handle. And I think it saved his life because, he didn't know what it was. And, he was kind of doing some self-treating on it and so on and so forth. But I said, we set it up. I did, and my nurses set it up, and we actually sent them on. I'm in Raleigh, Missouri. We sent them on to Columbia, and they drained it for like 2 or 3 days. And then, then he came back here, and we started doing work on him. He's doing really good now. That was about 3 or 4 months ago. So, but he had this big abscess, and they said they said that thing was close to bursting. If it bursted, he was gone, because sepsis would have ran rapid through his whole gut area there. All right. So potential patterns associated with infection. I really want you to pay attention to this, because this is an important thing. So you don't just look at CBC, and this is where a lot of doctors fail in this. Even doctors doing functional work, they only look at what's going on with that CBC. They look at those differentials. They look at you know what the white blood cell count is, and so on and so forth. As a matter of fact, a traditional medical doctor won't even consider infection unless the white blood cell count is over 10.8. And most labs are at 10.8. And I got to tell you, I have found literally hundreds of infections that are lower, and I would say 95% of the infections I find with elevated white blood cell count is above 8 or even above 7, but lower than 10.8. So they're missing out, but their job is to save lives from acute infections, not chronic ones. They're not really dealing with those kind of patients. We are, so that's the way it works. Okay, so elevated RDW, anytime it's over 14, you want to consider an infection. It could just be that they're inflamed from some other reason, but you want to put that as part of the pattern. So in other words, you look at your CBC, you're going to see your white blood cell count, you're going to look at your differentials to see what's going on there, and then you're going to look at these things here. Elevated cholesterol, LDL. A lot of times people forget about this one, but what does LDL do when it's it's a taxi cab when it carries cholesterol? What does it do? Well, it helps you make hormones. It helps you metabolize vitamin D, but it also helps build the brain. You have to have cholesterol in the brain. So another thing it does, and probably one of the most powerful things it does, is it puts out inflammation. So where it gets the press is if you have inflammation on the inside line of the arteries and you don't have enough vitamin C in that basement membrane. And by the way, if you're inflamed there over a long period of time, you'll run out of vitamin C locally there, and there's no way you could take enough vitamin C to make up for that. It just doesn't work that way. But your vitamin C goes so far down, and that's an antioxidant. Well, so is cholesterol. Here comes the LDL over to the artery to put the fire out. Well, if you have small particle LDLs, they can get stuck in the inside line of the artery and cause a whole process that actually leads to an autoimmune process on your cell wall. First, you start off with inflammation, which goes to oxidative stress, and the immune system starts going after those torn up epithelial cells. All right, so if you have elevated cholesterol, like let's say it's 220 or 230 or whatever, and your LDL is up, think infection, think inflammation and infection, if it fits the pattern with the other parameters for your infection patterns. All right, so BUN, this one, you don't see this one a lot. This is generally only when there's a viral infection. If you have a viral infection, it can go lower than 13. And the reason why, because lower than 13 means a congested liver, and viruses like to attack the liver. So if you have BUN lower than 13, that would fit a pattern for viral infection. If it's over 18, that would fit a pattern of bacterial infection. But keep in mind, anything that causes inflammation in the body can raise the BUN. Now, of course, that's relative to creatinine. So when I say elevated, it's BUN is elevated relative to creatinine, because creatinine and BUN should go together, and it's a reflection of kidney function. But if your creatinine is in the normal level, but your BUN is high, that means you're either dehydrated or you have a ton of inflammation in your system, and certainly a bacteria could cause that ton of inflammation. Okay, alkaline phosphatase. If this is elevated, and not just, I actually like to see the alkaline phosphatase in a tight range, about 60 to 80. But when the alkaline phosphatase gets over 120 and higher, or out of clinical range, one of the things you want to consider is an infection. Of course, you want to also consider some kind of cancer process possibly could go on, especially if it gets up to 200 and above. All right, so altered AST here again, viruses love to attack the liver. Elevated LDH. Well, sometimes your body's fighting so hard to get rid of this infection, and it's in a crisis, and it's just trying to make more fuel, taking as much glucose everywhere, and you're just manufacturing all kinds of glucose and converting it into energy, and that's the LDH. And then acute phase reactants. Of course, anytime those are up, you want to think about bacteria. All right, so I think we're in a good place right here. Do we have, Dr. Annette, do we have any questions?
Nope, not right now.
Okay, very good. Well, let's continue on then. All right, so some common labs for acute bacteria. So if you have an acute bacteria, here are some of the things that you can see on the labs. Neutrophils high, lymphocytes decreased. Most common presentation, not the only, like we talked about. Lymphocytes elevated with neutrophils decreased. A few bacteria can do that, but some can. And my experience is you usually find that in GI infections. All right, so acute phase reacts, we talk about that. Positive ones are the elevated CRP, ferritin, fibrinogen, complement factors, HDL. You can run all those tests. Depressed, acute bacterial infections can depress the cholesterol, can depress the albumin, transferrin, and transthyretin. Okay, other findings. Elevated protein, elevated BU and creatinine ratio, depressed TSH below 1, altered iron. And I didn't say that before, and perhaps I should put this in this section. But keep in mind, bacteria love iron. Why? Because they use iron to reproduce, right? So for them to colonize and just keep on going and build momentum to really go after it, these bacteria can multiply rapidly when they have supplies of iron. So sometimes what you'll see is your total iron. Now remember, total iron is not the total iron in the body. It's just what's running around in the blood. So when your total iron goes high or low, either one, it is a pattern that fits bacteria. Pattern that fits bacteria. Usually you're going to see it low. And let me just say this. Let me back up because I really want to make this clear. We've got a lot of cases to go through. We're going to have to kind of speed up a little bit here, but I want to show you something that I think is very important about this iron and looking at the iron and your other factors. All right, so these are the secondary factors right here. So if you see, I'm going to give you the strongest indicators of chronic infection or even acute. If you see elevated cholesterol, elevated LDL, but it doesn't really fit a cardiovascular. You look at their cholesterol to HDL ratio, and it's sitting at like 3.5, which is perfect. So it's not a cardiovascular case. This is something else. If they don't have a low thyroid, one of the things that can cause this elevation is an infection, and we see it actually quite commonly. I find it more commonly in chronic infections, but you can see it in an acute as well. So that is a big one. Let's see, out of this one right here, TSH is a big one. And looking at iron status, total iron, and even ferritin. If ferritin is way high, higher than it should be, or low. So ferritin, iron, and these are things that are, when I look at the blood work, I look at these things very specifically. In fact, when I suspect there might be a chronic infection with a patient, I want you to jot this down. Number one, of course, we're going to do CBC with differentials, right? Number two, I'm going to order a TSH. I'm going to order a CRP. I'm going to order a ferritin, minimally a ferritin and an iron, just like that. I mean, you have to, you really have to consider running those. And I'm going to get a lipid panel because I want to look at these things. So if I'm trying to figure out if somebody has an infection, and I'm also going to do a CMP because sometimes you can see those liver things going on with the liver. So I'll do a CBC, CMP, TSH, LDH, TSH, LDH, CRP, ferritin, and iron. So this is the one that you want to look at. So you want to look at these 7 things. If you suspect some kind of infection, I'll tell you when I use this. When somebody comes in and it's in the afternoon, it's a usual patient that I've had, and I suspect maybe they had a downturn of symptoms, I suspect an infection, I will run this panel minus the lipid because they're not fasting and it's not going to help me. I can't really judge it that well. So I'm going to run these things: CBC, CMP, LDH, TSH, CRP, and ferritin iron. This is going to be my panel. That's my really quick infection spot check because these are all the things that fit the pattern of that. Now remember, they've had a downturn in symptoms and they haven't added or changed medication. So therefore that totally fits the pattern of an infection. Now I'm going to do that and probably run a urinalysis, especially if it's a female. Okay. So let's move on and let's actually start talking about some cases here. Here's a patient came in with a chief complaint of excessive mucus. It's been going on really her whole life. She's from Ukraine and she had it there, and she came here, she had it. Now she thought she had SIBO. I'm not sure about that. She might, but I don't really think so. It was something else. But anyway, she does have excessive mucus. Why? Because look at this. Look where that TSH is. 0.27. Does that fit the pattern of infection? It certainly does. CRP is elevated. Does that fit the pattern? Yes, it does. All right, so let's look at the white blood cell count. 6.7. It looks normal, but now come down here and look at the differentials. The neutrophils are high, 60%. Monocytes are high. That's a real good indicator of one of two things. Oh, I shouldn't say it that way because it's really not. It's an indicator of a bacterial infection. Look at the platelet count, 336. That's kind of in that chronic infection place, right? So she's got a lot of things. So she has 1, 2, 3, 4 very good indicators that give us an analysis for pattern, and that's what it is. And so now I know she's, I'm pretty sure this is a bacterial infection. So, and then this is her BUN. It's lower than 13, right? Okay, so all the rest of that really looks okay. This is a congested liver. Might not have anything to do with infection, but it might. It fits the pattern, usually a virus, but we see it there. All right. So this is, I have to see how long this was. 528. Okay, this is the same, this is the cholesterol and all that. So let's move on. Urinalysis was clean. Then we came back in a couple of months. Actually, looks like 3 months. That she still has a little bit of infection. She's a lot better, but this has been a chronic infection that's been there forever, and she actually has some kind of lung problem that makes it easier for her to get infections. Her blood sugar came down. That's good. Her TSH was 0.27. Now it's 0.188. Okay, so she's making progress there. Her neutrophils are sitting at 67. They come down a little bit now, but look what's going on here. I love this. So it was at 6.7 her white blood cell count, but now it's 8.4. What is happening here? Well, her immune system is finally engaging in this thing. So it'd been laying there for probably years, just laying there off and on, and she's not fighting it very well. The immune system's kind of just putting up with it and trying to just survive with it. Well, we started initiating things. We did some vitamin C IVs, we did liposomal vitamin C, and we did silver. That's basically all we did to fight infection. But we also got the body tuned up by getting that liver healthier and all the things, going through blood sugar boot camp and all that, right? So we tuned things up, but now her immune system says, hey, wait, we got to go after this. And that's why this is getting better. And that is why this TSH number is coming up. It's coming up. And so here's another thing. When you're looking at chronic infections, you have to have a benchmark to determine if they're getting better or not. That's what I love about rerunning the labs. You rerun the lab, and you can look at things like TSH. You can look at other things and see if they're improving. Her C-reactive protein, remember it was at 15. I'm going to back up. Sorry to make you dizzy, but I just want to back up and show you this. Here's a C-reactive protein at 15. Now, it is sitting at 5.4. So we're getting better. And it took 3 months to get there, but that's a chronic infection. And now it's actually turned into like the immune system is looking at it like an acute infection because the white blood cells have elevated. Okay, 55-year-old female, fatigue, body aches, weight gain. If you see that combination in history, you must do a urinalysis. You must. All right, because once ladies hit perimenopause, menopause, estrogen goes down. When estrogen goes down, the pH changes, and it makes it more suitable for E. coli to proliferate. And 90 to 95% of bladder infections, UTI, come from E. coli. Not the only bug that can do it, but it's the most common. So you have to do that, right? So white blood cells, 5.2. It's getting close. Neutrophils at 62. Lymphocytes at 28. Now, I'm going to share with you something that a lot of people may disagree with, but I've just seen it so much, I believe it, and that's this. If you have a chronic bladder infection or a chronic any kind of bacterial infection, the longer it's been, the closer the neutrophils will get to 60. And in this case, that's pretty classic. You have a bladder infection going on. It's low grade. The patient doesn't even feel it. But what they do feel is they've had fatigue, body aches, and weight gain for the last 3 years. That's what they feel. But they don't realize, because when they go to the bathroom, they don't feel any pain. Their back might hurt a little bit, but they don't associate that with a bladder infection. So we have, 62 here, a little bit above. And I will tell you for sure, if I see a pattern like this with white blood cells that are getting close to being low, and a pattern of neutrophil lymphocyte like that, I get suspicious of infection, right? And so I start looking if there's any other patterns of fit. Look at this, LRDW is high. Look at this, platelet count's high, right? And not only that, but of course we did a urinalysis and we saw she had a few bacteria in there. Do you know what a traditional medical doctor would call this? A traditional medical doctor would look at this and put yellow tape around it and say nothing to see. And I'm not criticizing the traditional doctor. They're just not looking for this. And the reason why is because they're okay with a few bacteria in the urine. I am not. But we have different functions, different purposes. But at 5.2, he or she is not going to think anything. It's not over 10.8. So he or she's not even considering it. And by the way, I want to make a little plug right here. If you run, this is a dipstick urinalysis that we ran right before we did this. And look at this, leukocytes did not show up, nitrates didn't show up. Now I think that there's a lot of usefulness for the dipstick UA, especially when it comes to bilirubin, urobilinogen. You can, it's a good screen for diabetes. When you have glucose in your urine, it means the sugar is at least 180, and some people could trigger it at 160. Protein in the urine, if you have a bunch of protein in urine, that's not good. So this is a good test, but not a good test for infection. If you see nitrites on this, there's an infection, but it's just not very sensitive to pick up those infections. So go ahead and run your lab, send it off the lab. I think they're what, $8, $12, something like that. I'm not sure, but it's not that much. Okay, so 47-year-old presents with rapid onset facial numbness and tingling. So okay, think about this. You're a doctor, somebody comes in, and they're 47-year-old female, and they present with rapid onset facial numbness and tingling, significant heaviness in both arms, pressure, back of the neck. Now, there's one thing in this clue that shows us that it's probably not a stroke, even though it looks like a stroke. Any kind of rapid symptom, you want to think of what's going on neurologically, what's going on with blood flow. Did she have a stroke? That kind of thing. But watch this. She had significant heaviness in both arms. Strokes don't generally do that. Strokes do one side or the other, right? The most common. All right, so I just want to show you this. They ran off, if you went to the hospital, they ran a bunch of CTs, MRIs, because they were like, hey, what the heck is this? Now look at this. This is what they found in the ER. White blood cells, 8.74. Neutrophils, 67%. Lymphocytes, 23%. This is a very classical, and 7.9 on the monocytes. This is an infection. Now watch this. They did, okay, well, let's look at this. This is not what I'm looking for, but let's just see. When total protein, you know what? I am so sorry. I was completely remiss when I talked about these patterns, because I just put these patterns together and I was, trying to organize this for you. But sometimes when you're sitting in the chair, it's different than when you're sitting and seeing the patient. But I want you to put this in your memory bank. Protein that is above 7.5 can be one of two things generally. One is dehydration, but the other, and the one I find most common, is inflammation. And the closer you get to 8 or above, that inflammation is generally a bacterial infection. Okay, so put that in your memory bank. That, I told you the list. CBC with differentials, CMP, and you'd catch the protein with that. LDH, TSH, CRP, ferritin, iron. That's your pattern. That's your quick spot shot looking for infection. But the other thing you want to put on that CMP to look at is you want to look at the protein. Has it elevated? And particularly, remember, protein and calcium kind of approximate each other. When one goes high, the other goes high. When one goes low, the other goes low. They kind of go together. So relative, we like to see the calcium at 9.4 to 9.7. Well, as it turns out, this is 9.4, and we like to see protein 7.1 to 7.5. Sorry about the writing, there's bottom of the page. So this is a 1. So protein's a lot higher here. This is part of the pattern for infection. Part of the pattern for infection. And here's BUN that's low there. Liver enzyme, I'm sorry, transaminase is low, should be 18. This one should be 18 to 26. I don't know what that was. Okay, so now look at this. This is the part I wanted to get to. Now, remember, the white blood cell is 8.5 or something in that area. Neutrophils are at 70%. Now look at this. She has cloudy urine. She has blood in the urine, and drum roll, please, she has 4+ bacteria. Now, here's the thing. What they told her at the hospital is this is normal. That's what they told her. Now, to give them the benefit of the doubt, this was an emergency room. In the emergency room, their job is not to, actually, it wasn't the emergency room. Okay, so, but the emergency room's job is not to fix things like this. It's to see who's going to live and die and separate and push them somewhere else. This was actually not, I don't think this was done at the emergency room. Okay, so we did a urinalysis. She had bacteria in her urine, and that was 910, and this is 968. She had bacteria in the urine, and we put her on a bladder protocol, which consisted of this. We had her take uva ursa. We had her do silver, and we did vitamin C IV. Now, in lieu of a vitamin C IV, you could do heavy doses, maybe 8-10 grams, 6 to 10 grams of vitamin C daily for 2 weeks while you're doing this with the uva ursa. So you can use vitamin C, silver, uva ursa. Usually works pretty good, unless it's not E. coli. Then you have to come back the next time if the bacteria is still present. You have to send off and get a culture to see what's wrong with it. Okay. So after we did that, all the symptoms went away. Within 2 weeks, all the symptoms were just gone. And you'll notice this. If somebody has something that just comes about, especially rapid onset dementia for older people, or anything kind of weird that's all of a sudden showing up. Viruses usually don't make things all of a sudden show up. It does it more in a slow progressive time. Bacteria likes to do things right now, rapid. So when you see this real quick, all of a sudden this happened, and we saw that urinalysis, I will have to tell you, quite frankly, I did not know if that was what was causing the problem. I did not know, but I know clinically that we have seen some crazy things happen when you get rid of bladder infections. Now, here's the deal. Most doctors don't know to look for that. You take a urinalysis. I take a urinalysis on every one. If I don't want to making a misimpression here, but I believe that I take a urinalysis on every one of my menopausal ladies who come in. I always run a screen on that, because so many times we'll find things, more times than you would realize if you're not doing it. You can also do it on younger females and a man if you have some suspicion, other patterns in the history that kind of lead you that way. They're having prostate issues or stuff like that. Okay, 20-year-old female presents with 3 episodes of syncope in the past 2 days. Well, she'd been at a fraternity party for 2 days, and then, she was probably there for 2 days, but she was there for an evening, and then 2 days later, she starts passing out. If you have females that are passing out, there's 2 things you need to look for. They probably already had hypoglycemia, and then you put an infection and usually a UTI on top of that. If they already have the tendency, they have a weak autonomic nervous system. If they go into hypoglycemia and then they get a UTI, crash, they pass out. This is just like if you ever watched a Pet Detective with, what's his name? Anyway, he gets hit with a dart, and he said that's 1 dart too many, right? And so that 1 dart too many is the UTI. So this is what she had. I just want to show you this real quick because we've got a lot of things that we want to accomplish here. Okay, I just see high white blood cell, which is suspicious of infection. We see, when we look at this one right here, we've got the white blood cell count at 9.6, neutrophils at 72. Guess what? She has an infection. Okay, so, and this is her blood. All right. Where's my neutrophils at? Oh, those are absolutes there. Okay. Anyway, that I just skipped off to another case. Basically, the passing out got better. We worked on blood sugar. and we got rid of the bladder infection, same way as we did the other, but we did not do an IV on her. We just simply on her, we just did silver and uva ursa, and it worked out beautifully. Okay, there's the next, here's the next case study, 9-year-old female. So looking at the mouth here. So you see that right there. You know, it looks like probably a virus, but let's look and see. So we did some tests. Alkaline phosphatase is low, which is kind of interesting because usually in kids they're high. She does have high ALT, so viruses like to go after the liver, right? And she has the neutrophil lymphocyte, right? Should be 60-30 if you're not fighting anything, but her lymphocytes are high and her monocytes are high, which fits the pattern of infection, probably viral. So we used some viral immune stimulator, which is some type of homeopathic, and then we used HSV, herpes 1, 2 combination of a homeopathic, and we used some vitamin C. I love using homeopathics that are specific for the virus. Here's another one. This one came in 6 years old, boy with eczema for 4 years. What is the first thing you think about? Well, the first thing I think about is food sensitivities. We did food sensitivities, or actually he'd already been doing food sensitivities from our lab and really didn't have any results, which was surprising. So this is the picture before, if you see that, and these are painful, they itched, he couldn't sleep, it's just horrible and been going on for 3 or 4 years there. All right, so we did blood work, and I don't see a lot there. Actually, I do. If you look at this, the BUN is actually higher relative to creatinine, so that's one thing. All right, look at that platelet count, right? Look at that. White blood cells are 7.4, but kids have higher ranges for white blood cells. But look at this, lymphocytes, instead of 30, they're at 59. And neutrophils, instead of 60, they're at 30. This is a big viral infection. And not only that, but the ferritin is low. So here's before and after. Here's the before and after. He did this in 2017, but he came back a few years later just because the family was visiting, and I seen his mom as well, I think, or something like that. But anyway, this is a picture 3 years later, and so, or 2.5 years later, and it was clean. He hadn't had a problem since. Now I do have a couple of ones that I want to go through because it's so important. I've got 2 more I have to go through here that I think you'll benefit from. Okay. So long-term patient downturn. So I've been seeing this patient for 5 years. 3 months ago, he started having symptoms. He's having a little breathing issue, not a lot, but just a little more, kind of coughing things up. And but it kind of went away. He'd had COVID, and that's what happened after COVID. But after a little while, that went away. A week or two, it went away. So 5 years prior, patient started as a patient with entrance complaint of anxiety, depression, GI symptoms of IBS, symptoms resolved following 3 months of care. So we put him on food sensitivity. We did some gut repair, not anything more fancy than we usually do, right? On these kind of cases, blood sugar boot camp, you know, hadn't followed food sensitivity, did some gut repair. That was it. And he did better, right? So post COVID, pretty much all those symptoms came back. He's feeling anxious, but he's also feeling really depressed and blue. This guy's really happy, and he just wasn't. And anyway, also had IBS. And then labs ran 2 months after COVID, and those are the original symptoms. This is what we found. Look at this. Cholesterol's good, but look what's going on with the LDL. It's raised. Why? Because it's fighting an infection. His AST is elevated. That might be related to infection, but I'm not sure about that. I don't really want to put my head on that too much. But look at this, the LDH, which I like to see about 140 to somewhere about 180, right? It's 210. So he's fighting an infection. But watch this right here. Anytime you see this, myelocytes, absolute myelocytes, band cells, any of these are immature. They're immature white blood cells that go after bacteria. And because they're immature, the reason why you get them out there is because the body's fighting this infection that's having a hard time dealing with. So it just starts recruiting the younger ones and tells them to come out of the bone marrow, even though you're really not technically ready for it, right? So what happens in these cases is that when you see that, you usually have a bacterial infection going on. That's certainly what he did. We did 2 IVs on him, vitamin C IVs, and had him take some liposomal C with silver. And within a couple of weeks of doing that, all the symptoms went away. And I show you this because this is just a downturn, right? So now here's what I want to do before you all come off of here. Okay, we still got all our people. That's good. All right, so we have, this is a little plug, and I want you to pay attention to this. If you want to learn how to do some of these things we do, we teach a DABCI program, Chiropractic Internists. It's a board certification under the auspices of the ACA. It is a fantastic program. I'm saying that I teach a lot of it, but I'm not doing that self-serving, but it really is a fantastic program. It's where I really gained a lot of my knowledge base. It's 8292. Oh, Lord, forgive me. Okay, so